In this video, we are going to discuss about cholangitis. First of all, what's cholangitis? Cholangitis is biliary duct obstruction leading to stasis and infection in the biliary tract proximal to the obstruction. It's also referred to as ascending cholangitis. So let's see the anatomy to make things more clear. So intrahepatic left hepatic duct and right hepatic duct will form the common hepatic duct, the perihilar area. Extension of the gallbladder, which is the cystic duct, will combine with the common hepatic duct and form a common bile duct. In the pancreas, the common bile duct will combine with the pancreatic duct and finally enter to the duodenum as a sphincter of Oddi. So here there is the head of the pancreas, there is a sphincter of Oddi, and the duct system here. So what are the causes of cholangitis? That means what causes the obstruction initially. So most of the time it's due to biliary duct stone, around 85% of the cases. The others include malignant conditions, including the tumors in the gallbladder, the bile duct, the ampulla, the duodenum, or the pancreas. It could also be benign biliary strictures, maybe congenital, post-infectious, including AIDS or cholangiopathy, or inflammatory conditions, including primary sclerosing cholangitis. Flux can also cause mechanical obstruction in the biliary duct, and it can also occur following procedures like RCP and post-operatively due to bile duct injury or stricture. So once there is obstruction of the biliary duct, there will be stasis. So what causes the bacterial infection? How does the bacterial infection occur once there is obstruction? So before seeing how the bacteria get there, what are the natural mechanisms that prevents entry of the bacteria into the biliary tract, which is normally sterile area? So the sphincter of Oddi is a mechanical barrier to duodenal reflex and ascending of bacterial infection. Continuous flashing of the bile and the bacteriostatic activity of the bile cells also decrease colonization. Secretory immunoglobulin A and biliary mucus also act as an anti-adherence factor, so preventing bacterial colonization. So bacteria are able to enter into the biliary tract when the normal barrier mechanisms are disturbed, including after endoscopic sphincterotomy or choledochal surgery or biliary stent insertion. And biliary obstruction by itself can raise intrabiliary pressure, which leads to increased permeability of bile ducts and permitting translocation of bacteria and toxins from the portal circulation into the biliary tract. Elevated pressure also favors migration of bacteria from the bile back to the systemic circulation, which leads to increased risk of septicemia. This pressure can also affect a number of host defense mechanisms, including Kupffer cells, bile flow, and immunoglobulin A production. And bacteria can also spontaneously get through the sphincter of Oddi in small numbers, but in the presence of a foreign body like a stone or a stent, it can act as a nidus for bacterial colonization, which leads to infection. So what are the common bacteria involved in acute cholangitis? So culture is positive in 90% of the cases with a yield of mixed growth, including E. coli, Klebsiella, and Enterobacter species, which are gram-negative, and Enterococci species, which are gram-positive, and Bacteroides and Clostridial species, which are anaerobes. So it is a mixed feature. So what are the symptoms and signs of acute cholangitis? Charcot-Triad and Raynaud's pentad are the terms that we use in describing signs and symptoms as collective. So Charcot-Triad include right upper quadrant pain, jaundice, fever, or chills, which are present in 70% of the patients. And the Raynaud's pentad is Charcot-Triad with shock and change in mental status, and which occurs only in 15% of patients. So how do we diagnose acute cholangitis in addition to the signs symptoms? What are the investigations? Right upper quadrant ultrasound often demonstrates dilation proximal to the obstruction. There will be increased white blood cell with left shift, increased bilirubin, alkaline phosphatase, and amylase, and ARCP on percutaneous transhepatic cholangiogram. If ARCP is unsuccessful, ARCP is not only diagnostic, we also make a decompressive procedure, which is also part of treatment. So finally, how do we treat acute cholangitis once we diagnose? The first thing is antibiotics should be broad spectrum, as we have discussed. It is mixed pathogen including gram-positive, gram-negative, and anaerobes. So we should start ampicillin plus gentamicin, or we can use also levofloxacin plus or minus metronidazole if disease process is severe. Severe means in-organ damage, shock, are the main characters of a severe form of acute cholangitis. We can also use carbapenems, piperazine, tazobactam also. 80% of patients respond to conservative treatment and antibiotics. So biliary drainage can be done on elective basis, but around 20% of patients require urgent biliary decompression through ARCP, papillotomy, stone extraction, and or stent insertion. And sphincterotomy cannot be performed in case of like large stones. Decompression by biliary stent or nasobiliary catheter can be done. If this fails, one can do percutaneous transhepatic biliary drainage or surgery. So thank you for watching. Subscribe and like for more educational videos.